Regarding the incidence, placenta previa differs. During the first half of pregnancy, the sonographic incidence reaches up to 50%. However, at term, this incidence decreased due to what we call placental migration and differential growth of the uterus. That's to say, the placenta does not move, but the uterine wall, with the progressive growth and enlargement of the length of the uterine wall itself, the actual site of the placenta differs from one time to another. Placenta previa more common in multipara, especially of old age, represents 1 in every 20 pregnant women. And it is rare in primipara, represents about 1 per every 1,500 cases. Regarding the etiology of the placenta previa, first of all, it could be idiopathic. The second cause is due to low implantation of the ovum associated with deficient decidua. And this is associated or considered in some obstetric cases like old multipara, women with previous cesarean section, and deep curettage. Any scar in the uterine wall could lead to deficient decidua, and this may lead to low implantation of the placenta of the ovum, and subsequently placenta previa will develop. Or the third cause may be abnormally large placenta by itself, like conditions, for example, diabetes mellitus, Rh isoimmunization, and placenta membranaceae. The risk factors or predisposing factors for placenta previa include large placenta, such as those associated with diabetes mellitus, Rh isoimmunization, placenta membranaceae, twins, previous uterine scarring, as we said before, such as previous cesarean section and deep curettage, multipara, especially of old age multipara, defective vascularization leading to defective decidualization, and this will cause placenta previa. The placenta previa has 4 degrees or 4 types. First degree, we call it low-lying placenta. Second degree is called as marginal placenta previa. Third degree is called as incomplete placenta previa centralis. And the fourth degree is called as placenta previa complete centralis. From clinical point of view, we call first and second degrees as placenta previa of minor degree. Third and fourth degrees as placenta previa of major degree. This simple clinical classification reflects the possible conduct of delivery, the possible route of delivery. For placenta previa of major degree, no vaginal delivery, only delivered by cesarean section. For placenta previa of minor degree, which are first and second degrees, vaginal delivery could be an option. In this slide, the following figures demonstrate different types of placenta previa. In figure A, the placenta just encroaching in the lower uterine segment. This is type 1, as we call it, low-lying placenta. In figure B, the placenta lies in the lower uterine segment, but the lower edge does not reach the level of the internal os, 2 centimeters or more away from the level of the internal os. In figure C, the placenta occupies the lower uterine segment, and the lower edge of the placenta is covering the internal os when it is closed. and covers it partially if it is opened during delivery. So we call it placenta previa centralis incomplete centralis. And in figure D, the placenta occupies the lower trans segment and covers completely the internal os, whether it is closed or opened. Regarding the clinical presentation of placenta previa, most of cases are asymptomatic, 50%. This is the commonest presentation. The other 50% of cases presented by abnormal vaginal bleeding, as we said before, antepartum hemorrhage, which bleeding from 28 weeks gestation up to onset of true labor pain. It has three specific criteria, painless, causeless, and recurrent. The source of bleeding comes mainly from large sinuses in the uterine wall from which the placenta is detached, and the amount for first attack usually is variable, but recurrent attacks may be dangerous as it may lead to sudden shock. On examination, by general examination, the degree of shock is proportionate to the amount of blood loss. By abdominal examination, the abdomen is lax, the uterus is not tender, malpresentation is very common, and the fetal heart sounds are audible. No vaginal examination could be allowed. Vaginal examination is contraindicated. These signs contradict that associated with the other cause for antepartum hemorrhage, which is accidental hemorrhage or abruptio placenta. In other words, in accidental hemorrhage by general examination, the degree of shock is disproportionate to the amount of blood loss. By the abdominal examination, the abdomen is rigid, not lax. The uterus is tender. However, in placenta previa, the uterus is not tender. Malpresentation is common in placenta previa, but cephalic presentation is more common in accidental hemorrhage. Fetal heart sounds are audible in placenta previa, but not audible in accidental hemorrhage as the fetus usually dies. And in both conditions, no vaginal examination could be allowed. By investigations, as you see, ultrasonography and magnetic resonance imaging are the best for diagnosis of ultrasonography, for diagnosis of placenta previa. This is a picture of ultrasonographic appearance of placenta previa. As you see, the lower edge of the placenta is completely covering the internal os. This is placenta previa complete centralis, or placenta previa of major degree. By MRI, more sensitive, more specific, but more expensive. As you see, the arrow demonstrates the site of placenta, which occupies the lower uterine segment, and it covers the internal os completely. This is a case of placenta previa complete centralis. Regarding the risks or complications of placenta previa, it could be associated with hemorrhage leading to shock or anemia. The incidence of placenta accreta accounts for 5% of such cases. Abortion, premature labor could occur. The risks of malpresentation and non-engagement of fetal head, and subsequently the increased rate of caesarean section is very common in such cases. Postpartum hemorrhage, retained placenta, and puerperal sepsis are also associated complications with placenta previa. Regarding the management, your decision depends on 4 factors. First, the amount of bleeding, whether it is severe or mild to moderate. Second, the gestational age. and this reflects the maturity of the baby, whether the fetus is mature or premature. The third factor, whether the patient is in labor or not in labor. And the fourth factor is the degree of the placenta previa. Treatment options may be either expectant or conservative management, and it could be allowed at home or as outpatient clinic, or the treatment may be an active intervention. For expectant management or conservative management, the lines of expectant treatment consists of complete rest, hospitalization could be allowed, investigations in the form of CBC to check for hemoglobin level, blood grouping, and you have to do urine protein, fetal surveillance with repeated ultrasonography and non-stress test, blood transfusion to correct anemia if it is discovered at any time. We can give tocolytics, drugs to relax the uterine muscles. This is given if vaginal bleeding occurs, since it is associated with uterine contractility and this may induce premature labor, so we give tocolytics to relax the uterine wall. We give also corticosteroids to improve fetal lung maturity and reduce the risk of respiratory distress. And lastly, Rh immunoglobulin could be given to all Rh negative mothers. This is the lines of the conservative or the expectant management. Here, this algorithm summarizes the active management of any case with placenta previa. As you see, placenta previa confirmed by ultrasonography. Our management depends on whether there is bleeding or no bleeding. If there is bleeding, gestational age 37 weeks or more, terminate by cesarean delivery. If less than 37 weeks and the maternal fetal condition is unstable, terminate by cesarean section after controlling the general condition of the patient. If it is stable, we can conserve for some time. If it is less than 34 weeks, give corticosteroids, admit in hospital for observation, do the usual investigations until 37 weeks or more and terminate. If it is more than 34 weeks gestation, admit in hospital for observation and continue in the conservative treatment till reaching 37 weeks, then terminate by cesarean section. If there is no bleeding, this is also depends on the gestational age. If it is less than 28 weeks, continue on the conservative management until one of two options. The placenta previa resolved by ultrasonography. In this condition, vaginal delivery could be allowed, and this is usually in placenta previa of minor degrees, which are first or second degree placenta previa. Placenta previa not resolved, complete rest, repeat ultrasonography till reaching 36 weeks of gestation. If placenta previa resolved by ultrasonography, vaginal delivery could be allowed. If not resolved, do amniocentesis at 36 to 37 weeks to check for fetal lung maturity. Mature, deliver by cesarean section. If not mature, continue on the conservative treatment till reaching 37 weeks and then terminate by cesarean section. Thank you very much for your attention.